Hello everyone. This presentation is on Irwin Rosenstock's health belief model that was developed in the 1950s. Irwin Rosenstock was a professor and chair of the Health Behavior and Health Education Department within the Public Health Administration program at the University of Michigan from 1961 until his death in 2001. He developed the health belief model along with other researchers during the early 1950s when he worked for the United States Public Health Service. The health belief model is one of the original behavioral theories developed to help predict health-seeking behaviors with regards to preventative medicine. The health belief model is based on the work by Kozel and Cobb. Rosenstock was the first to introduce the components of what is now known as the health belief model. Kozel and Cobb's work was influenced by the ideas of Kurt Lewin. There are links between the health belief model and other behavioral models such as social learning theory by Albert Bandura. The health belief model was later modified to incorporate a component of the social learning theory referred to as self-efficacy, which is discussed later. The focus of the health belief model is to determine or be able to predict how a person will behave in order to prevent getting a disease based on their perceptions. The main premise of the health belief model, according to Rosenstock, is that the goal of understanding and predicting behavior should appropriately precede the goal of attempting to persuade people to modify their health practices, even though behavior can sometimes be changed in a planned way without clear understanding of its original cause. The main concepts of the health belief model are referred to as constructs. In the original model, the constructs developed include the perceived susceptibility of a disease, perceived severity, then perceived benefits, followed by perceived barriers, and lastly, cues to action. The perceived susceptibility is the understanding or fear of contracting a disease. The more fearful they are, the more likely they are to seek treatment or accept recommendations of a healthcare provider. This leads to perceived severity, which is their perception of how bad the disease will be if left untreated. Their perceived benefit of seeking treatment is taken into account. If a person has a high perception of susceptibility, likely perceives the treatment to be more effective. The perceived barriers are related to the person's understanding of how difficult a treatment or modification would be, such as cost, pain, or inconvenience. Being a nurse, I have met many patients who refuse to get a flu shot because they fear they will get the flu or have an incredible fear of needles. This is where we as healthcare professionals addressing these issues and educating patients on the benefits of getting a flu shot, painting the picture of how severe the flu can be and that a quick shot is more beneficial to their health based on the ideas that I've seen in the health belief model. The perceived benefits must outweigh the perceived barriers in order for a person to act on a particular recommendation. Depending on their perception of these four areas will depend on how much of a cue of action is needed to help encourage seeking the recommended treatment. A cue to action are triggers to get people to change. Warnings on the side of a cigarette package, television commercials for medications, or physician recommendations are all examples of a cue to action. Another construct was later added to the health belief model in the 1980s based on Bandura's social learning theory called self-efficacy. The social learning theory tries to predict or understand human behavior as it relates to social interactions. This is a person's belief that they are able to perform the recommended behaviors. As stated earlier, the foundation of the health belief model is based on components of work done by Kozel and Cobb. However, they did not create the theory or a behavioral model that was applied in the research in the manner that the health belief model has. The health belief model also has its origins based on the theories of Kurt Lewin, who believed that behavior is influenced by a person's perception or subjective understandings and not objective. To analyze and evaluate the health belief model, the components of internal and external criticism based on Barnum's recommendations that are outlined in Peterson and Bordeaux will be used. The internal criticism is the internal construction of the components of the theory, of how the theory fit together. whereas the external criticism considers the theory and its relationships to people, nursing, and health. Within the internal criticism of the theory, we must first evaluate if it has adequacy, which is defined by Peterson and Bradeau as how completely the theory addresses the topics it claims to address, establishes if there are holes or gaps that need to be filled by other work or further refinement of the theory, addresses if the theory accounts for the subject matter under consideration. Based on the literature reviewed, the health belief model does possess adequacy, as the theory does address the claims made by Rosenstock. The theory looks to understand people's perceptions, to understand how healthcare can change, to address issues related to prevention strategies, compliance with medications, vaccinations, and other diseases. Rosenstock has been able to address any gaps or criticisms by other researchers of the health belief model on perceived inadequacies in areas such as long-term treatment compliance. The next component of internal criticism is clarity. This is defined by Peterson and Bradeau by determining if the theory clearly states the main components to be considered, determines if it is easily understood by the reader. The clarity of the health belief model is evident in many publications by Rosenstock and other researchers who have applied his theory within healthcare. The main constructs of the theory have been well defined in early publications by Rosenstock, as well as other researchers who use the health belief model and reference his early works for definitions of the health belief model. Its use was well described in Rosenstock's publication from 1966 that outlines the 5 original constructs of the theory, which are easy to understand and follow. The next evaluation tool is consistency, which is defined by Peterson and Bradeau as whether the theory maintains the definitions of the key concepts throughout the explanation of the theory, determines if it has congruent use of terms, interpretation, principles, and methods throughout. The health belief model is consistent in its definition of the constructs and how the theory is used. The constructs have been easily applied in other literature while using the same definition of the construction, such as that described by Mayman, Becker, Kirsch, Hafner, and Drachman, where the definitions of the 5 constructs come directly from Rosenstock's published works. Even literature published in 2015 continues with the same definitions of these constructs. Then there is the logical development that resolves the question, does the theory logically follow a line of thought of previous work that has been shown to be true, or does it launch out into unproven territory with its assumptions and premises, as defined by Peterson and Bradeau? The health belief model was originally developed to understand why people would not seek out preventative treatment recommendations and how they could change their perceptions to affect the outcome of diseases. While the original theory and early publications have been questioned about this logical development, one can argue that the theory does have a logical development as it continues to be effectively used in research 50 years later. The last evaluation tool is determining the theory development, which is defined by Peterson and Bradeau as the stage of the theory determining how long it has been around and how often has the theory been put to use by other researchers applying the theory and publishing results based upon it. Based on the age of the original publications by Rosenstock and the history of the theory, the health belief model has a well-aged theory that has been around for about 50 years. The theory has been used in independent research studies and is still seen today in 2015, such as the example by Park et al. That tests the use of the health belief model instrument to investigate people's perceptions and treatment of chronic pain from arthritis. There are many examples that empirically support the health belief model as a theory that can be used to develop knowledge. The external criticism of the health belief model is evaluated by examining the complexity of the theory, which Peterson and Bradeau define as how many concepts are involved as key components of the theory, decides how complicated the description of the theory is and if it can be understood without lengthy descriptions and explanations, considers the number of variables being addressed, and exists on a continuum from parsimony, limited number of variables, to complex, extensive number of variables. The health belief model has 5 constructs from the original theory, with the sixth added later as the theory was modified. Compared to other behavioral theories such as the trans-theoretical model, the health belief model should not be considered a complex theory. There are many more components to something such as the trans-theoretical model, which make it much more complex. The second step to examine the external criticism is to examine discrimination, which determines if the theory is able to produce a hypothesis that will lead to research results that could not be arrived at using some other nursing theory. How unique is the theory to the area of nursing that it addresses, and does it have a precise and clear boundaries and definitive parameters of subject matter, as defined by Peterson and Bordeaux? The health belief model is designed to understand a person's perception related to utilizing preventative medicine or looking at illness treatments. Comparing the health belief model to other behavioral theories, it does discriminate as each model looks at behavior areas of how a person behaves related to their health. These include social interactions such as Bandura's social learning theory, or the trans-theoretical model that looks at how a person is ready to change. Some of the literature found related to the health belief model clearly state hypotheses that can be tested and applied to practice, such as those described by Mattson and the research related to HIV prevention. The health belief model does have a distinct method for determining people's perceptions related to disease prevention or illness and treatment. The references for this presentation has 5 examples applying the health belief model, each looking at a different disease. The next step is to examine the reality convergence as per Peterson and Bordeaux, which determines if the theory's underlying assumptions ring true, decides if the theory's assumptions represent the real world, and if it represents the real world of nursing. Does the theory reflect the real world as understood by the reader? The health belief model does have a real-world practicality that has been used over the last 50 years. The health belief model is a middle-range theory, and while it has been used to explore perceptions related to illness and prevention, there remain limitations related to the feasibility of the health belief model examining preventative behaviors of healthy people. But the original theory does remain intact for those who use the health belief model for the design of their research. Following reality convergence, the next evaluation tool for external criticism is pragmatic. Peterson and Bordeaux define this as if the theory can be operationalized in a real-life setting. The health belief model has been seen extensively and played a huge role in how practitioners provide patient education, as proper education about disease and effective treatments are key to getting patients to act on their abilities. Providing adequate information about the severity of a disease, the treatment options that exist, and how someone perceives a disease is important when looking at compliance to medication usage. The next step examining external criticism is scope, which Peterson and Bordeaux define as determining how broad or narrow is the range or phenomenon that this theory covers. Does it stay in a narrow range of scope to keep it a middle range theory? The scope of the health belief model can be considered narrow, as there is a lot of limitations listed in the literature about the theory. Of the many research articles using the health belief model, they have all stayed within the range of the theory. Then significance of the theory is evaluated and is defined by Peterson and Bordeaux as the result of the research that, because of the hypothesis generated by the theory, have any impact on the way nurses carry out nursing interventions in the real world, or does it merely describe what nurses do? Does the theory address essential, not irrelevant issues to the discipline? One example of how the health belief model has displayed significance to nursing care is evident in a study by Mattson that applied the health belief model to examine safe sex practices as a preventative measure for HIV. This study tested 4 hypotheses through the health belief model as a way to determine how to improve counseling sessions for safe sex practices to decrease the spread of HIV. Lastly, the external criticism evaluates the utility of the theory, which is defined by Peterson and Bordeaux as being able to determine if the theory can be used to generate hypotheses that are researchable by nurses. Again, the study by Matson provided insight that affects how practitioners can address education provided to patients related to safe sex practices and preventing HIV. Other research has also provided information on how to increase compliance to medication regimens and other treatment options. Within the health belief model, there have been many instruments developed by researchers as a way to apply the theory. One study conducted in Iran in 2014 created a health belief instrument that included 4 parts, including a 39 questionnaire to determine the people's motivation and understanding of osteoporosis and treatment options. Questions were developed for each of the components of the health belief model, as well as a few questions that were added to an additional question to determine if a patient's self-regulation or self-efficacy were adequate. As part of the data analysis, the researchers were able to test the instrument's reliability. The researchers successfully used the instrument that added to the original health belief model constructs to help provide a better understanding of osteoporosis prevention behaviors. Another study published in 2015 created the arthritis-related health belief instrument based on the health belief model. The instrument had already been created, but in this study they were applying it to 4 different ethnic groups. This instrument contains 14 questions that cover 4 subscales, which are the 4 perception constructs of the health belief model, including severity, susceptibility, barriers, and benefits. This study has found positive results using the instrument and that it can be used among a variety of ethnicities to examine patients' perception of efficacy in using non-pharmaceutical treatments to treat arthritis. The health belief model has provided a foundation to ascertain knowledge related to people's health beliefs and personal understanding related to specific diseases, treatments, or medical interventions. The utility of the theory and its applications to nursing research has been tremendous. There have been many specific examples of areas of healthcare that have been tested using the health belief model over the years. Some of these examples have been reviewed by Carpenter, which include tuberculosis testing, smoking cessation, mammogram testing, flu vaccines, medication compliance, and dental care. As stated earlier, while reviewing the internal and external criticisms of the theory, the study by Matson used the health belief model to study unsafe sex practices in relation to the transmission of HIV. This was a field study that tested several hypotheses related to HIV test counseling through survey testing in both pre- and post-intervention. The results did not show that the health belief model was able to confirm the hypothesis stated at the beginning of the study with regards to susceptibility and severity, but they did find that perceived benefits outweighed the perceived barriers in the study. While all the hypothesis statements made were not confirmed, this study did provide insight as to the extent of what cues of actions are needed to be taken as an HIV counselor in promoting safe sex practices. Another study by Pinto et al. From 2006 used the health belief model to develop an instrument that could be used to create a test to understand diabetic patients' pharmaceutical treatment compliance and determine what else is factored into their perceptions of medication compliance. This is a cross-sectional study of diabetic patients who used a specific pharmacy to fill their medications and to test perception of diabetes treatment options and belief of effectiveness of education sessions. This study found that education through the pharmacist increased their perceptions of susceptibility and severity of the disease and knowledge related to the benefits of medication treatment. A third study by Blavos, Glassman, Shue, Dyer, and Deakins from 2014 used the health belief model to evaluate college students' alcohol drinking in relation to the use of medical amnesty policies when they felt someone had alcohol poisoning. This is a cross-sectional design study where students and professors answered a health belief model-based instrument survey. These researchers were able to use the data to find relationship about a person's willingness to use the service based on the health belief model. What the study found is that while the medical amnesty policies is exclusive to the university, the amnesty does not hold true to outside law enforcement. The barrier uncovered is that students are not willing to call 911 for alcohol poisoning for fear of legal implications. The study did also find that people understand that they do understand the severity of the disease. Ultimately, the results have shown that more education about the severity of the disease needs to be taught, and that the barrier of fear of prosecution needs to be less to decrease the number of alcohol-related deaths in college students. Looking at the health belief model utility from the 1960s and beyond, the initial focus was on understanding people's perceptions of preventative medicine. Rosenstock's theory was initially designed to understand how people felt about a disease, as well as the treatments or tests that were being used. The health belief model was a way to examine the effectiveness of communication strategies such as the Surgeon General's warning on smoking. Even today, there are commercials for a variety of vaccinations and medications available on the market as a way to promote awareness and education to the public. The success of this model has already brought the future of the health belief model, as researchers are trying to apply it to chronic illness and disease as opposed to prevention. These examples are illustrated in the work done by Pinto et al., Blavos et al., that were described earlier. In conclusion, the health belief model has had a lot of success and utility over the last 5 decades and continues to be used in today's research. The longevity of this theory and variety of usages has also shown that it is pragmatic, adequate, and consistent in its success. Thank you.